Welcome back to complete our discussion on Crohn's disease. Joining me once again is Dr. John Fucci. He's with St. John's in Sapulpa. You're also with OU School of Community Medicine as an associate professor, and you're a gastroenterologist and a hepatologist. Let's jump in. Now, I do want to ask a question before we get into some other confirmatory diagnostic methods that you would use. You mentioned before we left for break that sometimes there are people that have come in and have been suffering with this for 10 years even. If they are waiting that long before they actually come in, we often think, are they causing more damage? Is there something else that's going terribly wrong that had they had earlier treatment for would make this a better outcome?
Yes, that's very true. Certainly earlier diagnosis is better. One of the problems with Crohn's disease is it's a lot easier to treat the acute inflammation than when they get scarring. And particularly with small bowel Crohn's disease, if the disease progresses, you can end up with scarring in the intestinal tract that cannot be treated. It has to be done, removed surgically or some other method to take care of that kind of blockage. But when there's inflammation in the acute phases, we are very good at treating that.
Okay. Now, tell me about some other confirmatory diagnostic things that you do to be able to say this is Crohn's disease.
Well, probably the best test is colonoscopy. Our modern colonoscopes are able to examine the entire colon and even pop into the small intestine. So on 90% of the patients we see, we're able to get a good view of the entire colon so we can rule out Crohn's in the colon and also get into the small intestine by popping through a valve that separates the colon from the small bowel. It's called the ileocecal valve. We can pop through that, and often we can go 10, 20 centimeters up into the small bowel. And 90% of Crohn's disease will be either involve the colon or the last part of the small bowel. So colonoscopy can diagnose 90% of Crohn's disease. And it has a particular picture. You see ulcers of the colon or small intestine, inflammation, it's swollen, it's red. The ulcers are kind of looks, if I can describe what an ulcer looks like, if you took a hot poker on your hand and burned it, and you'd see kind of a yellow area and a red around that. That's what an ulcer looks like in the intestinal tract, because essentially the lining of the intestinal tract has been removed by the inflammation, and you're left with the underlying tissues. Okay,
well, let me ask this too, then, in relation to colonoscopies. Let's say a person may be pretty asymptomatic at the time, and they're getting a routine colonoscopy. Can you pick this up in its very early stages before the person really has some symptoms?
Absolutely. That's a very interesting point, because I have, in the course of evaluating people for routine colonoscopy for colon cancer screening, routinely I tend to look in the small bowel, and there's been studies how accurate this is in terms of the percentage of people you might pick up disease that was not present beforehand. And I have found ulcers in the small intestine and also in the colon. And when I discussed it with the patient afterwards, they'll say, you know, doctor, I have had some diarrhea, I've had some pain, maybe I haven't been telling you about this, or they really haven't come in for that particular problem. And we diagnose Crohn's disease, which has been mild previously, and we can start some treatment and perhaps prevent it from getting more severe.
Okay, this other quick question that I want to get into treatment then. Is this something that you should ask your doctor to do if you're going in for a colonoscopy, to do the small intestine as well, to try to, or is this automatically done?
No, it's not automatically done. Most gastroenterologists probably don't do it for routine colonoscopy for colon cancer screening, but if you're having diarrhea or abdominal pain, then you should discuss that with your gastroenterologist, saying, I'd like to make sure this isn't Crohn's disease, and make sure you look in my small intestine, my terminal ileum. And most competent gastroenterologists should be able to do that. Okay.
Now, treatment then, because we've talked about the major ways that you're going to diagnose this. What kind of treatments are available?
Well, the way we treat Crohn's disease is to try to modulate that hyperactive immune system. Okay. So in the year 2010, we have much more weapons to use against Crohn's disease than we did 20, 30 years ago when I started practicing. Generally, we use anti-inflammatory drugs. They're known as 5-ASA compounds, and they coat the intestinal tract, and they help with mild Crohn's disease, and they're taken in pill form. Often we sometimes use prednisone, which is, as you know, is an anti-inflammatory drug, And then the newer drugs we use are immunosuppressive drugs. One particularly one we use is 6-mercaptopurine, which suppresses the immune system. And the most exciting ones are the new biological ones. You might have heard of Remicade, which is also known as infliximab. And these drugs, this class of drugs, inhibit a chemical. It's called tumor necrosis factor alpha. Okay. And that's a big word, but what it means is these are one of the chemicals that rev up the immune system. So if you suppress this chemical that the body produces, you suppress that inflammatory reaction.
Okay, let me ask this question then. With these particular medication treatments, as you're treating it medically speaking, is this something the person has to be on for life, or once the inflammation, does it ever get under control where you can then come off of these drugs and only have to use them if they're flare-ups? How does that work?
Well, Crohn's disease typically can go into spontaneous remission after treatment. So what we usually do is to try to use these drugs to get the patient into remission. And what we mean by remission is that the disease symptoms have gone away and that endoscopically they have healed. And when that happens, we often use other medications to maintain that remission for a certain period of time. And if patients are in remission for over 2 years with no symptoms, often we can stop the medication. That doesn't mean they're cured, but they can sometimes go for several years without symptoms again. We continue to monitor them, and if they start having symptoms again, then we can start retreating. But Crohn's disease specifically can spontaneously go into remission and go away for even sometimes 20 years and then come back.
Okay, now with this then, in terms of monitoring the person, does that mean they need to have more frequent colonoscopies or what?
Well, more importantly, just talking to the patient is how we monitor them. We ask them how they're feeling. We see if they have any complaints of abdominal pain or diarrhea. And then sometimes we do blood tests to see if they're getting anemic or if they have any inflammatory markers. And then for certain diseases, more importantly ulcerative colitis, we sometimes do screening tests, colonoscopies, to not only just to see if their disease is active, but also to screen them for cancer, because ulcerative colitis specifically, but Crohn's disease, have a higher incidence of colon cancer because of the chronic inflammation. So those patients are going to be coming in even more frequently than the average person to have a screening colonoscopy for cancer.
Okay, in our last few seconds here, I want to ask you about the nutrition component. On the front end, you said it doesn't really seem to affect whether you develop it or not in terms of what we might be eating, although it can have consequences other ways. Once you know you have Crohn's disease, are there any kind of dietary restrictions or things you need to watch out for, or to make sure you eat?
Yes, nutrition is very important, and it is thought that too much fiber, unlike a healthy colon or a healthy small bowel, is hard on the intestinal tract. It's kind of like having I explain to patients, like having a pulled muscle, you need to rest it. And particularly people who have small bowel Crohn's disease can develop blockages if they eat too much fiber. Because if you have a lot of undigestible materials passing through the intestinal tract, they're more likely to get hung up on a narrowing. So we put them on a very low fiber, low residue diet. We monitor their nutrition. We make sure they take, there's certain vitamin deficiencies that can occur with Crohn's disease, particularly B12 and some other vitamins that can, and we supplement those, and nutrition is very important. And then, as we suggested, probiotics in the future may have a great role in this, where we can change the flora and may decrease the inflammation.
Thank you so much, Doctor. I know that was fast and furious, but we got many of the basics out there. Thank you so much.
It's been a pleasure.
Well, that's our show. For Health Alert, I'm Pam Butler. I'd love to hear your questions, comments, or suggestions for future shows. Please write me at Health Alert USA, P.O. Box 50913, Tulsa, Oklahoma 74150. Or if you're on the email trail, please email me at healthalertusa@gmail.com. And also visit me on YouTube at youtube.com/HealthAlertUSA. Take care, and if you've got any kind of symptoms, talk with your doctor. You deserve to have all that's good in life. Take care. This program would not be possible without the support of OU physicians in Tulsa.